And good morning, everybody, and welcome in to what Common Sense Matters this morning. Good morning, ladies. We've got Sandy Rice and Laura Heffman with us this morning. Hi, ladies.
Good morning.
Good morning.
How are you?
We're great.
Great.
Kind of cold this morning.
A little bit. But it's going to warm up.
Yes. Not after yesterday.
So what we got going on today?
We're going to talk about expanded and improved Medicaid, Medicare for all, and a few other issues in the news regarding health care coverage.
All right.
First, an announcement about from the Franklin County Democratic Party. The next meeting will be Saturday, February 17th, beginning at 9 a.m. at the Franklin County Annex in the small meeting room. Chairman Bob Zimmerman will be presiding, and there are usually some breakfast goodies, so come on down on Saturday the 17th. Again, my name is Sandy Rice, and I'm a retired nurse practitioner in family practice and oncology, and I'm currently volunteering 1 day a week at the Beersheba Springs Medical Clinic. My guest today is Dr. Laura Heffman from Colmont, who I met at a conference in Atlanta. Dr. Heffman, tell us about yourself.
Thanks, Sandy. I'm an emergency physician. I live in Grundy County, as you said. I've practiced both adult and pediatric emergency medicine for the past 31 years, the last 17 of which have been in Middle Tennessee and Southeast Tennessee, so this area and Chattanooga. I volunteer also on an as-needed basis in the Beersheba Clinic.
We are both members of PNHP, which is Physicians for a National Health Program, which supports two bills in Congress, SB 1804 and HR 676 in the House. Is for a single payer system for health care. Dr. Heffman, can you tell us what a single payer system is?
Yeah, well, first of all, just a little more expansion on the PNHP. It's a group of 20,000 strong, both physicians and other health professionals who feel that health care in the United States should be available to all, and that the only way this can be accomplished is by replacing our current system with a publicly funded type of system that would cover all Americans. We believe this can be done in a cost-efficient manner, which it can eliminate the wasteful practices that are in place today. Simply put, in a single-payer system, healthcare insurance, and therefore healthcare, is provided to all who need it by means of a centralized system. This would be administered in a similar manner to our Medicare for seniors, which by most estimates, both in my professional life and my personal life, I find most people find it extremely popular. They wouldn't give up their Medicare for anything. In our current fragmented system, healthcare is procured either through your employer, through your private purchase, which as we know is very expensive, or through the dreaded entitlements. And then it's parceled out into numerous private and for-profit insurance companies whose goal are to show profits for their stockholders first and then provide health care second. This leads to some problems. Each company has its own set of rules and regulations, making billing and collection a wasteful nightmare, both for our hospitals and for our doctors. In a single-payer system, healthcare dollars would be spent for healthcare, not profit. Medicare's overhead is consistently approximately 2% of their operating budget, which is pretty good by most business standards. Compare that with private insurance companies, where it's approximately 20%. In fact, one of the tenets of the Obamacare was that they couldn't spend more than 20%. If they spent more than 20% in administration, they had to give that money back to the consumer. And I actually did receive a few checks in the past few years for a little overage. I'd like to see that 18% of the operating budget that the insurance companies, in my view, waste, go back into clinics and hospitals and provide care.
Some people think that single-payer or universal health care would be socialized medicine. Socialism is a scary word that people throw around to suggest communism, government control of our lives. But we are not talking about government-employed doctors or government-owned hospitals or, heaven forbid, the politicians taking care of us medically, but a universal system that provides affordable health care for all Americans, like Medicare is for seniors. There are a lot of important things that we need to have available to everyone in America to make our lives, our economy, our country better and more efficient. We recognize, for example, that everyone needs to have a shot at a good education. We need a national program for our military, interstate commerce and trade, roads and highways, air and water. A national or pool programs really balance a capitalistic system in which the rich, or the top 1%, have 90% of the wealth. Dr. Helfman, I also hear people saying that the free market or commercial insurance should be allowed to fix health care. I tend to think the free market has created the problem of escalating health care costs, worsening health outcomes, and millions that cannot afford private insurance.
I agree with you. I think you're exactly right. In a single-payer system, finances are straightforward and simple. And both bills, both in the Senate and the House, would provide for public funding and private delivery of the system. I'll get back to that in a minute. The free market created the problem, in my view, because in a capitalist free market system, sick people are just not profitable. Their health care costs are more. The truth is that you can't look at health care the way you would look at the decision whether to buy a Mercedes-Benz or a Nissan. When you're sick, you want the best care. You don't want to be told your child's cancer is just too expensive to treat because the free market has decided that that drug, based on market predictions, would bring such a price, and therefore the price is artificially raised. So we are being held hostage to the pharmaceutical companies who can charge whatever they think the market will bear. That's the whole premise of free market. Such as many you might have heard of what happened with EpiPens, a life-saving, simple device that nurses at schools and doctors in hospitals and paramedics and individuals can use to keep themselves from dying from anaphylaxis. It was a $45 item when I was in med school in the early 80s, and it's now a $600 item because Bayer decided when they took over the company that that's what they could charge, and that's what they're doing.
And that's when people have a severe allergic reaction to like a bee sting or shellfish or something.
Exactly. In companies where healthcare is not a for-profit industry, the same drugs cost pennies, and usually there's no copay. So the same thing with surgeries. There are surgeries that occur in this country, I can talk about some that I've had, that would be a quarter to a half of what they cost in other very first world countries that would provide excellent care. And many people without insurance actually do what do they call it, medical tourism, to go off to get their hip replaced or their dental work done in other countries where they can pay out of pocket and it's reasonable. They say that in a free market where people have some skin in the game, in other words, personal out-of-pocket expenses, that they'll choose wisely and not squander their health care resources. What do you think about that choice?
I'd like to add, speaking of skin in the game, I had some skin in the game not too long ago. I'd like to tell a little personal story about my ability to choose or shop around for health care. A year ago, my finger was cut with a pruning shears while Christmas decorating. Bleeding, I went to the Swanee Hospital just 5 minutes away and was treated in the ER. There I was, a nurse with 40 years' experience in health care with a non-life-threatening medical problem. I didn't ask the cost of the care I was to receive. I didn't interview the doctor. I didn't call around to different hospitals for a better deal to fix my finger. I wanted them to stitch it up and give me a tetanus shot. The bill was hundreds of dollars, even after my insurance paid a portion. How does a person with chest pain, head injury, a fracture, shop around? The staff doesn't know how much stuff costs. I never did in my practice. I was just trying to take care of people. We don't choose our doctor now, hospital care, how much we will spend. The insurance company does make those decisions, and nothing is transparent. You can't figure out what's going to cost. Months later, we learn how much our health care costs, or if it is even paid or covered at all. We don't want the politicians or insurance company executives making our health care decisions. We want health care providers making decisions with us. Insurance companies are concerned, as Laura said, with profits. We have a dysfunctional health system where 32 million people have no insurance. Tens of millions more are underinsured, and most are at risk of financial disaster should they become seriously ill. Some of you know the hassles of getting an appointment or purchasing a medication. Believe me, the doctor's office has it all day, every day, and it affects what we can do for you. This was the case before Obamacare. It's not like we had a swell system and Obama came along and ruined it for everybody. Do you remember pre-existing conditions?
I remember pre-existing conditions very well. I am a living proof of pre-existing conditions, and the only reason that I'm here today in good health is because I was a physician and could treat myself early in the course of when I developed lupus. I was almost a year and a half into my COBRA insurance post-residency. I was in my 30s and I was very healthy. 2 months before that insurance was going to be over with, because that's how COBRA works. You can only get it for 18 months. That is the insurance you can buy from your employer when you leave that job to keep your coverage for an 18-month period to give you time to find new insurance. So 2 months before that was to end and before my next insurance was to start, I realized that I had lupus. Lupus is a connective tissue disorder that can be life-threatening and certainly lifestyle-threatening. And most people have a difficult time getting that diagnosis. It takes years. But mine was classic, and I was a doctor, and I said, oh my goodness, I have lupus. If I had gone to the doctor and made a formal diagnosis, I would have then been uninsurable. I wouldn't have been able to pay back my school loans. I might have been in poor health, and I might not be here today. I might not have had 30 years of a successful practice. But I was able to put myself on prednisone, which is a steroid. Many of you take it for bee sting problems or poison ivy. It allowed me to function. That allowed me to not go to the doctor for 3 or 4 months until my other insurance was firmly in place, at which point I made the diagnosis. And it got better quickly, luckily. Unfortunately, those steroids destroyed my hips, and in my 30s, I had to have both my hips replaced. Imagine if I had been uninsured. I would have been totally bankrupt, and I probably wouldn't have been well enough to be the physician that took care of people here across the street in Winchester and in Unity Medical Center and up in Sparta and down in Chattanooga at the Children's Hospital. I've really had a full career, and it's only because I was lucky and was able to make that diagnosis on my own. Most of you all wouldn't have been able to do that, and your lives would have been changed forever.
Yeah. Dr. Helfman, do you think we can afford this universal coverage? It'd be so great for everyone.
Yeah, I want to go back to something I talked about a bit before, which is the simple and straightforward way that single payer is administered. Again, both the bills, the one in the Senate promoted by Dr. Sanders and 17 other people, and the one in the House promoted by 130 or some odd representatives, including a couple in Tennessee and the western part of the state. What they provide is that the funds would come from a combination of personal and employer taxes, which would go into a single pool. This would eliminate the need for individuals to purchase policies or for employers to shop around and figure out what's best this year. Is it Cigna? Is it Blue Cross? Is it some Aetna or some other program? Each year employers spend money just figuring out which insurance to provide, and then sometimes individuals in a company get to choose from a few, but they're very complicated and complex, and some cover one thing better and some cover another thing better, and it's unnecessary for all of us. Each one of us now pays into Medicare. We pay a tax, if you will, at every paycheck, or self-employed tax if we're in a business, such as I am, where I pay my own. So we hope that we will enjoy health care when we reach 65, and some of you in the audience probably are 65 and could comment on how you like Medicare or not. In a single-payer model, the same concept is just extended to everyone. In every projected estimate, the increased personal tax and the employer taxes would actually be extremely, that would be a much lesser number than the amount that each of us pays in our premiums, our co-pays, our deductibles. If you add it up, we'd be spending a whole lot more than an increased tax, which of course everyone gets scared at the word increased tax. But in fact, it would be a tax decrease, because in place of your premium, which can be upwards of $1,000 to $2,000 per person for many people. I know that's what it is for me.
A month.
A month, yes, a month.
Mm-hmm.
That's with good insurance through my husband on Grundy County's, and it's an excellent plan. But to add to his plan for me is over $1,000 a month to give me excellent coverage. In place of that, I would pay increased taxes. Now, depending on your income level, someone like me, I might pay more. I'm okay to do that. I think it's important that we provide health care for everyone. So in this past year, U.S. health care expenditure surpassed $10,000 per person. What that means is for every man, woman, and child in this country, out there between government and personal spending, it's more than $10,000. Greater than 60% of that is provided by the government. In other words, Medicare, which is a big bulk of it, Medicaid, which is a much smaller part of it, that's the TennCare, and other programs in other states, the Veteran Administration Program, and the Indian Health Service. Those are government expenditures. So they're spending more than $6,000 a year already on every man, woman, child if you average it. That means the other 40% is covered by us, premiums, co-pays, deductibles. That number, what the government spends, the total number of 10,000 is more than double what most of the majority of developed countries spend in total on health care. So we spend alone more than other countries, and if we got better care, if we had better outcomes, if we were truly the best in the world in medicine, I would say, great, we're a great country, let's spend more money, and let's provide better care and have a healthier population. But I think, that's not true. We don't have a healthier population. In fact, we have a much sicker population in every outcome you can look at. And we'll get into that more in a bit. We do more poorly than the rest of our peer nations, the rest of our developed country neighbors who spend less per person. They spend less and they get more. That should be a capitalist concept. We want to get the best outcome we can for the least input of money. So we have an excessively, enormously complex, convoluted insurance system with an inflated administrative structure. And as I said, our outcomes are worse. In life expectancy, we rank 31st in the world, 31st, below some second world countries. And our life expectancy is going down. A child born today has a lower life expectancy than his 5-year-old sister did, and then his 10-year-old brother might. So we are going down because of our poor outcomes. Infant mortality, we're 38th in the world. It's scandalous for the amount of money we spend and for the fact that we are the United States of America. If we took away this administrative waste, brought it back to the doctors and the hospitals, instead of the administrators, maybe we'd regain our place in world leaders. We have the knowledge, and we're spending the money. We're spending more than anyone else. So with all that extra money, we could drive our numbers down, hopefully. And we estimate, PNHP does, that 45,000 deaths per year are unnecessarily caused by this lack of insurance or underinsurance, which I think Sandy's going to get to at some point.
Yeah, if we have time at the end, we've got even more scary statistics that will send you off calling your state and federal members of Congress. But I want to talk a little bit about a comment I often hear: why should I pay for someone else's health care? And there's a lot of anger directed at the uninsured and the poor on Medicaid. Let me pull my little soapbox over here and get on it briefly. We have a large chunk of our population that is insured. They have, I'm going to put Medicare coverage in there, but commercial insurance, where there's a lot of money spent, premiums, deductibles. It's very confusing, but for the most part, there is a group that can obtain access to health care. And then there's folks that are on Medicaid. This is seniors, people in nursing homes, a lot of children on TennCare, pregnant women, disabled children, young adults, veterans, mentally ill. These people in large amount can't work. I think there is a lot of opinion that these people are able to work. I fear that many states, including ours, will spend a lot of valuable resources, both financially and staff time, determining that people in this group can't work, are not able to work, are not able to maintain employment. There's one thing I was going to say.
Go ahead.
Okay, I'm sorry. It came back.
Go ahead.
So sorry. Then I lost it again. Go ahead.
Well, let me make some points while you're thinking about it. So that idea that there are all these people that don't work, can't work, unwilling to work, the fact is that most U.S. citizens that either don't have insurance or are getting subsidies if they were eligible for those, or who have Medicaid, are working. They absolutely are working. They just can't possibly pay the kind of premiums that it takes to get good health insurance. We just talked about this $1,000 a month to get good health insurance. Sometimes you can still pay $300 or $400 to have a $10,000 deductible. I don't know about anyone else, but I don't have $10,000 sitting around each year to pay until my insurance will kick in. So basically, they don't quite have insurance as I think of insurance, which has been very useful because not only did I have the other health problems we talked about, but last year I developed uterine cancer. I could get every bit of treatment I needed in an efficient manner. I had surgery within 3 days of diagnosis, and here I am with very little copays, just those things that are not covered, did I have to cover, and I could do that. So when people don't have insurance, they don't do those things. They don't rush to the doctor because they have a hint that something's wrong, because they're worried about the copays and deductibles, or even being turned away at the door, which happens very often. You know, you haven't met your deductible. We need X amount of money up front before the doctor will even see you. And we can talk about those evil doctors, but the truth is, with all the regulations they have, they can't afford to keep their practices open. I'll get into that later. So they don't go to get help until their disease is so advanced that the treatment's more expensive and their recovery is maybe uncertain. Maybe by that point that cancer has spread to another part of the body and it's not treatable. Maybe the lupus has caused kidney damage or lung damage or brain damage, and now they're never going to be back to where they were. And that is what people are doing when they have high deductibles and copays. So in PNHP, we have this term that's called underinsurance. Did you want to talk about it, or would you like me to?
I remembered my stuff that everybody has a neighbor or something that they think is taking advantage of the system, and I think this is where this anger towards and this reluctance to pay for other insurance programs, the public option. But first of all, you don't know your neighbor or your friend's financial situation, that they are on welfare, which includes really Social Security income and food stamps and that type of thing, not just Medicaid. You don't know their situation, and there may be people that are abusing the system, that they have extra money for a new truck every year or, a big party or something. And that's not right. Nobody's saying
we know those
right.
exist. That's for sure.
There is abuse at all income levels. Executives that are hiding money or using up the retirement savings. But so I hear about the uninsured and the poor. They should get a job. Many of the uninsured do work. They need to stop making bad decisions like smoking, drinking, eating the wrong foods, getting fat. You can think back on our patients, and everybody, does that. And who's going to judge? You eat too many Fritos, no coverage for you. So who are these uninsured people that we don't feel they deserve to feel well? Well, they may be artists, craftsmen, self-employed, shopkeepers, skills that don't fit into a large company or corporation format that can provide health insurance. They may be unskilled, although I don't think anybody's really unskilled. There are people that have skills that are not well respected by society and not compensated. Caregivers of the elderly or mentally ill at home or institutions, nursing assistants, nursing homes that hurt their backs, lifting incapacitated patients, food service workers, housekeepers, musicians, laborers. It often takes several of these types of jobs even to make a living wage. There are people that lose their jobs. I had a patient in Atlanta, a young woman who worked in a coffee shop, part of a national chain. She had benefits. She had severe anemia. She took 2 buses for over an hour to get to an appointment. Several appointments, but was let go for absenteeism. So then she didn't have insurance to have the procedure to stop the bleeding that was causing her anemia. So it just goes round and round.
Exactly.
Many veterans don't qualify for VA benefits. Have you heard of downsizing? Who gets laid off? Middle class, middle-aged workers in their 50s with house, family, and bills. It's hard to get another job to maintain that lifestyle, let alone pay for private health insurance. They have to struggle along the best they can, usually uninsured, until, guess what? They turn 65 and get single-payer health insurance. Medicare! There are also economic reasons for paying for others. Not everyone does well in school. Stuff happens. Pregnancy, drugs, poor grades, violence, injury. Many times the uninsured are young people with a lifetime opportunity to join the workforce or military and pay taxes. Women of childbearing age are in this group as well. Don't we want them and their children to be strong and healthy? They are the future of America. We can talk a little bit about ERs who are becoming so crowded with people whose health issues could be more cost-effectively dealt with in an office than an emergency room, and that endangers both our emergency rooms and the care provided in emergency rooms.
Yeah, well, let me talk about that a little bit. As you mentioned, I wanted to define the term underinsurance,
okay.
Which is when a person or family spends more than 10% of their income on health care costs. That's considered to be underinsurance because once you're spending that much, that means your copays and deductibles are so high that you're likely not to go to the doctor because of what we mentioned, either being not let in or being faced with a large bill that you're going to have to figure out how to pay just to be seen. That doesn't even talk about what tests you might need. So they come to the emergency department where a law called EMTALA says that we emergency doctors and hospitals that run emergency departments cannot turn anyone away, that we need to take care of them and stabilize them to the best of that hospital's ability, which means different things depending on how big the hospital is. And because of that, and I believe that that is a good law, because of that, we are really taking care of everyone. As I said, we're spending $10,000 per person. Some of that comes from all of the care that's being given to people who come in without insurance. It is estimated that reforming our healthcare system into a single payer with elimination of the for-profit middleman and all the administrative waste would lead to a $500 billion in savings in the first year. That's enough money to provide all the health care we need, and that's enough money to balance the budget. And there are facts and figures in both of those bills to support that. So they come to the emergency department when their disease is much more advanced. At that point, either we can't do anything about it, or we have to try to find specialists who don't want to see them because they remain uninsured. If they're sick enough to be in the hospital, everyone sees them. But if they're not that sick, they're sent out to find a kidney specialist or to find a lung specialist or to find a cancer specialist. And they are still without money. So if they had any money, they spend all of that. Now they're bankrupt. And now they are, in fact, getting insurance because they're getting TennCare. It's a round robin. We in our country are unique in the world in that more than 50% of our bankruptcies are in some way tied to lack of health insurance and health care problems. This does not exist in the rest of the world. In the rest of the world, they may still lose their job, as your patient did, but they would not lose their health care coverage because it's provided through a single system, through a publicly funded taxation system, and when you get sick and cannot work, you will still have your health care coverage. That's what I want to say about that.
What about the rationing and long waiting lines that we hear about in other countries that have national health insurance?
Okay. Rationing. We ration all the time in the United States. In fact, we ration more than the other countries. Here's how we ration. If you're rich, you'll get excellent care. It may not be quick. It actually probably will not be quick in most cases unless it's life-threatening. If you're poor, if you get care at all, you'll wait weeks and weeks to get an appointment and hours to days in some of our city's emergency departments in our overcrowded public hospitals. You can go to any hospital, you will get stabilized, but that doesn't mean you'll get continuation of care. If you speak to other countries, you'll hear complaints about certain procedures. Hip surgeries are always brought up, that there's long waits to get hip surgeries in Canada. Well, when I got my hip surgery, there was a 4-month wait, even with my good insurance. The only reason I got it sooner was because I was a physician. And that isn't fair. So there are long waits here for even those with good insurance, and there are certainly long waits in rationing for those without, which is a large percent of the population. It's probably only 50 to 60% of our population that actually has good insurance. There's a large portion with the underinsurance, and of course 32 million without insurance. The National Health Services in the United Kingdom and Medicare in Canada, they are actually a source of pride to all their citizens. They have problems, they complain, they strike here and there, but they're looking for it to get better. They're not looking to eliminate it. You will not find the majority of citizens in either of those countries or any of our neighboring countries in Europe wanting to scrap their system to go back to a capitalist system. They like that no one goes bankrupt doing the medical bills. And that's how it should be, in my opinion.
And the doctors can take care of them. They know that things will be covered, that the medications will be able to be procured, and
exactly.
And they'll be able to come back for return visits, and
right.
There's a lot less stress to not have to worry about those things.
There are numerous documentaries and comments made by doctors in other countries that are actually joining our fight here in the United States that talk about the fact that when they practice medicine, they practice medicine. People come in, they provide their Medicare card, which is what it's called in Canada, and they get their care, and at the end of the month, the doctor gets paid for every visit that they did.
One thing that is talked about, I know with Helen on this program, is jobs. My friend Beth in Atlanta was worried about all the people who do billing and work for insurance companies. What are they going to do if they're if we don't need them?
Right. That's a big concern. That was actually a concern that President Obama had when he went the direction he went. Because we basically, with Obamacare, kept insurance companies intact. Actually, both the House and the Senate bill have extensive plans to retrain and repurpose jobs. A new and expanded Medicare-like program will need significantly more mid-level workers for billing and coding and various other parts of the system. A healthcare system that covers everyone favors preventative and community outreach. And there will be plenty of work for many of the doctors and nurses who are currently working in the insurance company in the claims department, where part of their role is to deny, quote-unquote, unnecessary claims. Remember, that unnecessary claim is your health care, your child, your grandmother, yourself. Since 1970, the other people that would lose jobs, this is absolute, is the people in the upper levels of administration, and specifically the CEOs. Since 1970 has been a 3,000% increase in administrative costs in medicine, and some very large numbers similar in the number of administrators. And I've seen that in my 30 years, how many different types of levels upon levels of administrators there are, even in little hospitals like across the street in Winchester. These inflated administrative positions are part of the reason we're in so much trouble. The latest figures I've seen show that some of our big insurance giants, the big CEOs of Aetna and Cigna and whatnot, make between $25,000 and $50,000 a day, not a week, not a month, a day. I work very hard, I make a good living, and I think I deserve the living I make. But I cannot imagine what these fellows are doing to enrich our nation's health care that merits such outrageous salaries. If they want to be in business and make these large salaries, they should be in a business that doesn't affect our health and our lives.
You can tell that Dr. Helfman and I are passionate about health care in this country. We've not allowed anybody to call in with a question.
Yeah, so we should do that.
So if anyone has a question about expanded and improved Medicare for all, national health insurance, single-payer system, give us a call at 967-22011. Otherwise, we'll just keep on talking.
I have plenty to say. We wanted to talk about the aging.
Right.
Bankrupting the system.
Would our expanding aging population bankrupt a national health system?
Well, our expanding aging population is going to occur, whichever system we have. And they do use a large portion of our healthcare dollars, especially in the last 6 months of life. Some of this could be easily avoidable. If everyone got good preventative and supportive care throughout their lifespan, they may not have the severity of illness that they tend to have in their later years. Some of this expense might also be avoided if there was a government health system that provided resources to families so they could care for their loved ones at home. That's what most elderly want. You will rarely find someone that says, I can't wait to die in the hospitals with tubes and buzzers and whistles. They want to be home in their own bed, being cared for by their own family. Families just can't do it. if they had the resources in terms of what types of home care they might need, that might be equipment, that might be a home health nurse to do visits more than the once a week that's often allowed in Medicare. So their loved ones manage language in hospitals in a frightening and alone environment in their last days away from the people that love them. We would actually save money if we provided care in an appropriate manner. And we will have to provide care because the elderly are living in greater numbers because, as Sandy said, once you reach 65, your life expectancy jumps way up again. So if you make it to 65, you will then live into your 80s and 90s in the U.S., whereas if you don't make it to 65, now you're not expected to in many cases. So they will live long lives, and they are parents and our grandparents. They should live good, full lives, not alone in nursing homes.
What about medical research? Won't a publicly financed system, people ask, stifle medical research?
Actually, it would probably do the opposite. A lot of my colleagues say that in the hospital when I talk about this. They say that our medical systems have to charge what they do, and our drugs have to cost the best because we fund all the innovation. This is not done with healthcare dollars. The vast majority of research in this country is government-funded through the NIH, the National Institute of Health. It's always been that way. There has been an increase in research by corporations and drug companies, but the problem is their results favor whatever the bias is that they want that money to show. They've spent a lot of money to develop a drug. Now they want to show that it works. I can't tell you how many drugs in my lifetime, and more recently, in the last 10 years, are the great best drug, and then they're recalled within sometimes a year or two, sometimes a few months, because all of a sudden they find that there were side effects that were unanticipated because the research was not done vigorously enough. And now there is a push by our current president to allow drugs to get in quicker with less FDA oversight. If you're old enough, you might remember thalidomide. Mm-hmm. That was a drug that was
kept... Or if you watch Call the Midwife.
Oh, right, yes. So that was a drug that was kept out of the United States by a woman physician who was in a position in the FDA to do so. A lot of women in the U.S. got it from Europe, and their babies were born with shortened limbs or even no limbs.
And some more recent problems that fit that example would be Vioxx and Celebrex, if you remember those drugs, and increased incidence of heart attacks.
Absolutely.
And
if you look at the breakdown of what pharmaceutical companies in particular are spending, if you break the 100% down, actually about 17% goes to research and development, what they call R&D, and about 35% goes to advertising and marketing. And you can see that in all the TV
and the
ads.
Evening news.
Yes.
Yes.
You can see that. A big one is the push with Tamiflu, which in fact doesn't really provide that much support for the flu, but is so touted by the drug company that's reaping fortunes in profits, when all it will do is decrease your symptoms by about 18 hours. It's not a panacea. It doesn't necessarily get you better, and especially in kids, it has a lot of side effects. Mm-hmm. But not only is it now being told to you about it by the commercials, but every newscaster is talking about this life-saving drug, which in fact it isn't. Mm-hmm. So a lot of the claims they make are just false.
And a lot of times the medications advertised are for such a small part of the population. I worked in cancer care for many, many years in Atlanta, and there's a medication called Neupogen that helps support the white blood cell count so that chemotherapy could be administered on time. Many times we had patients that a family member would administer this at home or come back to the office. That wasn't that big of a deal, really. It could be in a rural area, but the product that's advertised injects it automatically and costs thousands and thousands of dollars.
I do know this because I was on this drug, and it actually retails for $9,000 or $10,000. But if you go to GoodRx, if you happen to be uninsured and have to pay for it, you could then get it for $5,000. That was your discount
for
price
one shot that you might
for
need every
one
3
shot.
or 4 weeks.
Yeah.
Okay.
So
What about doctors in this country? Do they support a single payer?
Actually, they do. Not all have delved into it as much as we have to understand the ins and outs, but 50 to 60%, well, I would say 100% of doctors favor doing something different than what we have now, because what we have now is not working, and we're smarter than that. But 50 to 60% favor some type of single-payer reform. They are concerned about a perceived lack of autonomy, but ironically, in a single-payer system such as Canada, which is publicly financed, it is primarily privately delivered. Most of the doctors are still in private practice, and the hospitals are independent. They're not government-owned or directed. Contrast this with here. Majority of U.S. doctors have sold their practices to the hospitals or the big groups because they've become employees themselves because they can't keep up with the insurance regulations. Doctors in other countries still like practicing medicine. The burnout rate in this country for doctors, even as early as residency, is extremely high. It's a national crisis that's being talked about in the AMA, in my own organization, the College for Emergency Physicians, and just about everywhere you look in the medical literature. They are rushed. They have to see more patients in the time period than they want to. They are a slave to the computer because it's not the computer itself. It's the number of regulations that have been put into place by the insurance companies that if you don't document this, that, and the other, it doesn't really matter that I had a toenail problem back when I was 2. It's supposed to be in the medical record for it to be complete, for me to charge the appropriate amount that I can. So we're a slave to the computer and the insurance companies, and we can't spend time with our patients. If we don't do that, if we actually sit face-to-face without the computer in the background, which I'm sure many of you have experienced, we take longer, and then we get in trouble for not seeing enough patients in the right amount of time. I have resisted that. You will never see me typing on the computer when you see me, if you happen to come in and see me. And it takes me longer, or I have to work an extra hour or 2 at night at home to finish my charts. In a system where when the doctors know things will get paid for, they know their patients can be seen when they need to, they will get the tests and the medicines they need with a minimal of overhead. Drug prices are significantly less because those countries are allowed to negotiate with pharmaceutical companies. Our people are not. When Medicare Part D went into effect, part of the way that the pharmaceutical companies accepted it was that the Medicare was not allowed to negotiate at all for prices with Medicare, and so we pay the highest prices in the world, sometimes 2- and 3-fold more than what other countries pay. Now, if you talk about not doctors and how they feel about single payer, some upwards of 60 to 80% of citizens favor some kind of universal system, and almost everyone knows someone who has Medicare who does get, sometimes with complaints, but does actually get the care that they need.
Is there any support in Congress for universal coverage, especially after the fight over Obamacare, repeal and replace, and now we have really, it's on the back burner.
Right.
There is. Burner.
In fact, there was a growing support in the Congress for the past 10 years. There's been a bill that gets introduced and reintroduced, the H.R. 676, a new and improved single-payer Medicare for all. It had 60, 70 supporters up until recently, and there are now somewhere around 130. It changes because, we've had a few people leave Congress and other people join Congress. Then Senator Sanders had a bill that was, he was the only supporter until last year, and he now has 17 supporters, co-sponsors. So there is a move for increased acceptance in Congress that we need to make a change, and that it probably needs to involve some type of universal coverage. We heard some of our Congress talking about the fact that maybe you shouldn't buy an iPhone, instead you should buy health insurance.
Oh, yeah.
I think that led to a groundswell of anger among constituents, and I don't think anyone would make those kind of thoughtless statements anymore. The problem is Obamacare hasn't fundamentally changed our system. It's just delivered a little differently, a different type of financing for some people, inefficiently and wasteful, and we can't go on with it. We need something different.
Oh, they're moving the phone over here. Does that mean we have a caller?
I think so.
Okay, what? Hi. Welcome to Common Sense Matters. Do you have a question for us?
Yes, in an observation. I had just recently had a trip to Canada, and I made it a point of asking almost everyone I met, Canadian, how they liked their healthcare system, and would they change it. Well, they had a lot of recommendations to it, but when I asked them if they would change it to a way that the United States operates, they said in no way would they want to go with the way the United States operates. Most of them were content with their system. They wanted to make it better, but they wouldn't change it for anything, and that was a big part of their happiness in their life. And I wondered if you had any thoughts on why do you think people in the United States are so against this type of universal health care? Is it because they've been so indoctrinated for this freedom thing that we have here that they've tied in health care with it? I'll hang up and let you kind of talk about that.
Yes,
Thank you very much.
Thank you for your comment and your question. I visited Canada twice in this last year, and asked people in restaurants and people on the cruise ship I was on, and they're overwhelmingly are satisfied. But why do you think we're so resistant here?
I think they have been indoctrinated. I think that those people who stand to make profit from keeping the system as they are, and the profits, I don't have all those facts and figures, are staggering. Again, this is a system we have where their main purpose is to make profit for stockholders, not to provide health care. They spend a lot of money in Congress. They spend a lot of money to indoctrinate all of us to think that we're a country of freedom and we would not want to have the government tell us what to do. That's ironic, because Medicare is the government, and my father, who's 83, has had friends say to him, "Don't let the government mess with my Medicare." That makes no sense. The government, Medicare is the government, and it does what it does, as I said, for 2% administrative costs versus 20% for the insurance companies. There's a lot of powerful people that want to keep us thinking that a single-payer system would lead to worse health. In fact, we pointed out, I think, in many arenas where it would lead to better health. We would have the programs we need to help people make better health choices. We would allow people to go to work and go to education at the same time and not have to worry about whether they had health care or not. There are people who stay in jobs that they don't like because they're afraid of health care. All of these things would be fixed if health care was taken off the table. As Sandy said, we pay for the police department. Everyone pays for the police department if they pay taxes. Do the people who don't pay taxes not get police protection? Of course they do. Do the people who don't pay taxes not get to drive on the road? Of course they do. And you could say that for all of the other things that we do, such as education. Everyone is entitled to an education. We could talk about whether education gets enough money. That's another issue. But we don't say that someone who's so poor that they don't pay taxes doesn't get to send their children to school. In fact, the opposite. We're trying to lift them up so that they won't be in the same situation their parents were. So yes, absolutely, you hit it on the head. We couldn't have said it better.
Yeah.
So thank you for your call.
Fair tactics. Good. Do we have a few minutes?
3 minutes.
3 minutes. Okay.
Take it away.
Well, I was going to talk briefly about Medicaid expansion. Tennessee, along with 17 other states, did not choose to receive monies through the ACA for what we call Medicaid expansion. We have people at a certain low income level that have Medicaid, and we have the people at a higher income level that have commercial insurance.
Which here is TennCare. That's how most people would know it.
But the Tennessee legislature was hesitant to take any federal money to help insure 731,000 people in Tennessee and 48,000 children. So since this decision was made, we've lost $1.4 billion in federal funding for fiscal year 2016-17 and $739 million in fiscal year 17 to 18. I hear all the time, I don't want my tax dollars used for X. So Tennesseans, here your federal tax dollars being sent to Washington instead of being used here. Our state legislature is currently in session. You might want to just check the paper, Google Tennessee Medicaid expansion, and learn a little bit more about what's happening, but we're losing a lot of money that we're paying in federal taxes, and we're not getting it back to help take care of some things in Tennessee, including treating the opioid addiction, which is reaching crisis proportions in our state, and hospital closures.
Yes.
Again, we're right across from a hospital
So
that I think is safe.
We should say before we close that there is an organization, as we talked about, Physicians for National Health Program, that has a website that could answer all your questions and more, pnhp.org. They're a wonderful organization, and that's where we got a lot of our information. There is a budding chapter in Chattanooga, and if you got in touch with them nationally, you could then get in touch with me locally. I know most people here maybe go to Nashville rather than Chattanooga. There is a big chapter actually in Nashville. I wish I had some contact information, but the office could give it to you. If you want to get involved, it's not just for physicians. It's actually for all citizens that are interested in this problem. Thank you so much.
Thank you.
Thanks, guys, for coming out and being with us today. Great show.